The broadcast is now starting. All attendees are in listen-only mode.
Well, good evening, everyone, and welcome again to another RX Question Lab workshop. Tonight, we are going to be tackling the gastrointestinal system, GI. So it's great to have all of you with us. We're going to dig into the complexities of GI, which is obviously a key area of knowledge for any aspiring physician and a significant component of USMLE Step 1. I am Jeff Downing. I am delighted to be your co-host tonight. And we're going to dive deep into a set of board-style questions. Our goal is to illuminate key concepts and provide you with some tools and strategies needed to answer questions like this, especially on test day. Joining me this evening is Dr. Abraham Titus. Abraham, would you like to introduce yourself to the crowd?
Thank you, Jeff. So as Jeff mentioned, my name is Dr. Abraham Titus. I'm a hematology oncology fellow at the University of South Alabama. I've been a tutor with RX for, more than about 3-4 years now. So I'm excited to teach you guys, and I've been teaching students from Step 1 to Step 2 to Step 3 over the years and helped many students achieve their goals, and hope we can do the same for you tonight.
What we want to do is not only help you, get these questions right, but we also want to help you develop a methodology for answering questions, because, big part of Step 1 is not only knowing a lot and, studying and trying to cram as much into your skull as possible. That takes time, and it takes a lot of rigor, right? But you're also timed during this test, so you also need to be able to be efficient as you are going through it. So we're going to talk a little bit about our preferred method, but the key thing is that as we go through it, we want you to be thinking about how you can hone your own approach to answering these kinds of questions. Okay, so let's get started. We've got question number 1, and as I reveal the question, you're going to see something interesting here, right? And it's about what's not here, right? We don't show you the answer choices yet. And that's by design. What we recommend that you do is first you cover up the answer choices. A lot of your approach to answering these questions really needs to be built on focus. And the thing, if you cover up the answer choices, you can help prevent yourself from seeing maybe a term or a drug or a disorder or something that you feel like you're unfamiliar with, or something that's tripped you up in the past. We really want you to be very deliberate in how you're attacking each of these questions. So we say, first off, cover up those answer choices. Second step, read the lead-in first. So the lead-in is the question part of the item. So in this case, the lead-in is, which of the following embryologic abnormalities is the most likely cause of this patient's condition? Now, obviously, you could go through and read the vignette, which we will do, and some students will do that. They'll read the vignette and then they'll read the lead-in because that's the way it's presented. But the good thing about reading the lead-in first is that now you know what you're going to be assessed on, and as well as what kind of data you should be looking for when you read the vignette. Because by doing this, it helps eliminate, in some cases, the need to go back and reread the vignette. which sometimes you'll have to do once you get to the point where you know what it is that what question they're asking you. There will also be a few occasions where the lead-in is straightforward enough that you can actually answer the question without reading the vignette. That's much rarer. USMLE has eliminated a lot of those questions, but every now and then you are going to probably see some questions that will you could answer without actually reading the vignette. So with that being said, we first cover up those answer choices, then we read the lead-in, and then we read the vignette. Here we go. A 1-day-old male is examined in the newborn nursery because of failure to pass meconium. He was born full term and is otherwise healthy. Physical examination reveals that he has a flat face and upward slanting eyes with prominent epicanthal folds. Cardiac examination shows a holosystolic murmur that is best heard at the left sternal border. His abdomen is distended and the rectal vault is empty, but notable for a tight anal sphincter. An X-ray of the abdomen is shown. So again, which of the following embryologic abnormalities is the most likely cause of this patient's condition? Go ahead and go to the question box. Let us know how many steps you think it will take to solve this one as I hand it over to Abraham.
All right. Thank you, Jeff. Yeah, and what he said is very, very important. We have to read the lead-in. That's probably the most key part about the question, and being able to understand what you're actually looking for. Some of the stems can be humongous and long, and you can zone out easily reading them, but if you know what you're looking for by reading the lead-in, then it makes it easier. So in this situation, let's start going through and let's highlight some important words here so we can kind of figure out what we're looking for. So which of the following embryological abnormalities is most likely cause of the patient's condition? So think of embryological abnormalities and cause. So it's not just what the patient has, but you may want to think about the pathophysiology behind that as well. All right. So ages, I think it's always important. So 1-day-old male. So this is a newborn. Has failure to pass meconium. What is meconium? Well, you guys should know that. And the born at full term, otherwise healthy. But the physical exam is very important here. Flat faces, upward slanting eyes, and prominent epicanthal folds. That's ring some bells in your mind right now. Epicanthal folds is a buzzword there. Definitely know what that means. And you should have an idea of what this patient has in your mind. I'm going to go over to the end. Now it talks a little bit about the cardiac stuff. I think that's important and helps paint the picture. But if you caught it with the epicanthal folds, you don't need to worry about the cardiac side of things here. Abdomen is distended and rectal vault is empty, but the anal sphincter is tight. And then if you look at the X-ray, you should be able to see kind of something that shouldn't be looking like that. So take a moment, think about what this is, think about the underlying diagnosis, and then think about what the mechanism of that diagnosis could be. And really that's how step one is. It's a multi-step process. Take your time, don't jump right to the answer, but have that thought process in your mind. All right, so let's look at some of the options now. Right, so we have, again, 5 options. This is probably the most common one you're gonna see. You're gonna A to E. And what I like to do is I like to start with E and make my way up just so I'm not kind of rushing and picking the first thing I see. So I'll start with option E, a plug of meconium. Okay. Option D, persistence of the vitelline duct. Option E, imperforate anus. Option B, failure of recanalization of the small bowel. And option A, failure of neural crest cell migration. Think about this, think about what the patient has, think about the associations, and think about the mechanism of action by which the patient has this condition. And this is a very high yield condition as well. So we can definitely talk about this. Let's go through it. And I think the poll is going to come up shortly. And guys, make sure you guys pick an option. Even if you're not 100% sure, go ahead and guess. There's no penalty for guessing wrong.
Okay, everybody. So you've got the quick poll is up. Go ahead and take a shot. What do you think is the most likely cause of this this newborn's issues? Good to see we've got a good crowd here tonight. So we've got some good questions. So glad you're all here. Appreciate all of the questions and comments in the question box. Okay, so about 80% of you have voted, so I'm going to go ahead and close the poll. And let's take a look at the results here. Okay, so over half of you went with option A, failure of neural crest cell migration. A little over a quarter of you went with failure of recanalization of the small bowel. And then some of you went with imperforate anus and persistence of xylem duct. Okay, so with that, let's go ahead and hide the results and reveal the answer. And the answer for question 1 is indeed answer choice A, failure of neural crest cell migration. Well done, everybody. That is a good way to start tonight's event. If you didn't get it right, that's okay. That's why we're here. We're here to learn. We're here to get better so that we get these things right on test day. So for that, I am going to have Abraham walk you through it.
All right, good job, guys. So you guys got this one correct. So let's think about what the patient has. Let's look at the radiograph. Let's look at the physical exam, and let's kind of connect the pieces together. There's a unifying diagnosis that connects everything together. So failure to pass meconium is a common finding, and we got to be able to recognize that. Okay, so meconium is the first stool that the baby makes, and the physical exam here, the flat face, upward slanting eyes, prominent epicanthal folds, that is buzzword for Down syndrome. They're trying to describe a baby with Down syndrome. Now, they may do the same thing as when they get older, and that you just got to recognize that sentence there means Down syndrome. Now, let's connect the dots now. So what's Down syndrome got to do with any of this? There's a connection. Well, Down syndrome, the other clue here they're giving you for Down syndrome is the cardiac findings. The hollow systolic murmur in the left sternal border indicates a VSD, a ventricular septal defect, which can be seen secondary to the endocardial Cushing defects associated with Down syndrome. But that's not what the question's asking. The question's all about the GI tract. So let's shift our focus to what's going on. In the image, you see the dilated loops of bowel. So why are they so big? Is it because something's blocking it, or is it just because they're dilated for no reason? This is a condition called Hirschsprung's disease. It's a high yield condition, and it's associated with Down syndrome. You have to make that association. So whenever a patient with Down syndrome doesn't pass meconium, think about Hirschsprung's disease. Well, what is Hirschsprung's disease? Well, the idea of a Hirschsprung's disease is the nerves that actually cause the peristalsis and allow the intestines to move are not being made. The cells, such as the neural crest cells, are not being able to migrate to the intestines in order to form those nerves, in order to allow peristalsis to occur. That leads to dilation of the bowel and the stool to kind of just sit there. It's called aganglionosis. Okay, big fancy word. You don't need to worry about it. The idea is that absence of ganglion cells inside the colon. So that's why there's no peristalsis occurring. The stool just kind of sits there and the baby does not pass stool. That's key. Embryo isn't the biggest thing on the exam, but you do need to know a few things that are very high yield on there. And neural crest cells, you have to know your neural crest cells. That's always asked on every board exam, and you need to know those. Other options, failure of recanalization of small bowel. Well, even by looking at the image, that's large bowel we're looking at here. And that's likely not what's going on here. That's more of an atrasia, duodenal atresia, something along those lines. Imperforate anus, again, tight rectal vault does not mean, tight anal sphincter does not mean it's imperforate. It's just tight, and there's no stool in the rectum, which you would be seeing in an imperforate anus. A persistent vitelline duct, that's going down a whole separate pathway. It's not got to do with this. And the plug of meconium, well, there would be a clear sign where there is absence of dilation beyond that. And they wouldn't give you the whole history of Down syndrome and all these things like that when you're thinking of plug of meconium. Maybe they would go with a cystic fibrosis patient. That one, I can go with more E option. Definitely a lot to take in here. Every option's got a different answer associated with it, but high yield. Make sure you guys learn this for your boards.
Okay, there you go. You heard it from Abraham. Got to know your neural crest cells. Okay, so get that under your belt. With that, let's head to question number 2. Again, we're off to a good start, and what we're going to do is we're going to follow the same approach that we shared for question 1 by covering up those answer choices and reading the lead-in. Which of the following disorders is associated with this patient's current condition? Okay, so again, we're going to be taking a look at trying to figure out what's going on with this patient, and then the disorders that might be correlated with it. Kind of straightforward. So let's go ahead and read the vignette. A 20-year-old man comes to the clinic because of bloody diarrhea and fatigue for the past 9 months. He has no history of major medical illness, although he does report pain in the knees and hands that seems to worsen with his diarrhea. A colonoscopy is performed, which shows diffuse rectal hemorrhagic ulcers and multiple areas of rectal granulation tissue. So again, which of the following disorders is associated with this patient's current condition? Think about how many steps it'll take to solve this one as I pass it over to Abraham.
All right, so another question here. This one's a little bit shorter and no image associated with it, but some important features here that Jeff just talked about here. So let's kind of go through, highlight some keywords, and kind of see what the question is really pointing at. Again, this is not asking about the diagnosis, it's asking about the disorders associated with the patient's medical condition. So you got to think about what the patient's got, and then think about the associations with it. Okay, you got a 20-year-old man, bloody diarrhea and fatigue. Okay, so bell should be going off in your mind when you think. Not many things cause bloody diarrhea, right? You got to think about what could that be. 9 months is also kind of important here, but I didn't highlight that. And pain in the hands, knees. Okay, so we got some joint pain. That seems random. Why is he getting joint pain with bloody diarrhea? What's the association there? Okay, but it's associated with the diarrhea, so they're related somehow. And he has diffuse rectal hemorrhagic ulcers and multiple areas of rectal granulation tissue. Oh, that is what tells you the diagnosis. Everything before that kind of hints you at it, but really when you see that diffuse rectal hemorrhagic ulcers and multiple areas of rectal granulation tissue, you should be thinking of this diagnosis. And the associated disorder with that diagnosis is what this question is asking. So let's look at the options and let's try to make that connection. All right, so again, 5 options again, very common. You're going to see that most likely on your exam. Let's go through it. Option E, small bowel stricture. Option D, primary sclerosing cholangitis. Option C, primary biliary cholangitis. Option B, non-caseating granulomas. Option A, enterocutaneous fistula. All right, all different GI disorders, but what does the patient have and what is the associated condition for that disorder? Take your time, think about it, read over the question one more time, and pick an answer.
Okay, the poll is in progress. Take a look at those disorders. Figure out which one you would connect with this 20-year-old patient. Let's see. So we've got okay, about a third of you voted. I mean, I think we've got a prime candidate here that's emerging from the votes. but we'll see. Okay, give you a few more seconds and then we'll go ahead and shut down the poll. Okay, let's close the poll and share the results. So about almost half of you went with primary sclerosing cholangitis, whereas about a quarter of you went with non-caseating granulomas. But also, a number of votes for enterocutaneous fistula and primary biliary cholangitis. So a little more of a spread for this one. So that's good. So let's go ahead and hide the results and reveal the answer. And the answer to question 2 is answer choice D, primary sclerosing cholangitis. So once again, that is a W for the crowd. It was good. Again, just under half of you went with that one. But for those of you who got tripped up on that, that's okay. Abraham is going to show you where you might have gone wrong. Abraham.
All right, great job, guys. So again, if you got that wrong, don't worry. This was a little bit tricky because, you got to think of two conditions that are kind of similar but also different when you think about bloody diarrhea, joints affected, chronic, young guy that's having this. It's either ulcerative colitis or Crohn's disease, right? Those are the common. They're both inflammatory bowel diseases. Now, the classic here, the diffuse rectal hemorrhagic ulcers, that's the clue here for thinking more ulcerative colitis as opposed to Crohn's disease. Crohn's disease, we know, is more skipped lesions, usually doesn't affect the rectum, and kind of can go from anywhere, from the upper GI tract all the way down to the bottom of the GI tract, whereas ulcerative colitis starts on the rectum and makes its way up, right? The diffuse hemorrhagic, they use the word ulcers here. That's kind of a clue here as well, okay? So you can have extra intestinal symptoms associated with either of them. And in particular, in this one, the ulcerative colitis can have some joint pains and things like that. That's kind of going down the HLA-B27. I think I saw somebody mention that in the questions, which is great. That's also different association. Let's look at the options here. Well, I see 3 options here that are associated with Crohn's disease, actually. Enterocutaneous fistulas can be seen in Crohn's disease, non-caseating granulomas can be seen in Crohn's disease, and small bowel stricture can be seen in Crohn's disease. So that's kind of a little bit of a clue that points that, hey, if 3 things are associated with Crohn's, maybe the answer is not Crohn's. Option D, on the other hand, primary sclerosing cholangitis, is the only one associated with ulcerative colitis over Crohn's. Option C is also something that people always mix up C and D, right? Which one's biliary cirrhosis or biliary cholangitis, the other name for it, versus biliary sclerosing cholangitis. The key difference is that primary biliary cholangitis is an autoimmune disease. Think about it in association with if I have history of Hashimoto's, lupus, those are the patients that are going to get that one. It's an autoimmune disease where your body just damages the biliary tract with an autoantibody. Whereas option D is an association with ulcerative colitis. 2 separate entities, but they kind of present somewhat similar. And lots of little details about that can come up as well. But option A, B, and E are all associated with Crohn's disease, with the transmural inflammation, skipped lesions, and usually not diffuse rectal hemorrhage ulcers, which is seen in ulcerative colitis. Good job, guys, and hope you guys don't miss. If you guys got it wrong, next time, hopefully you guys get this one right.
Yep, well done. We are so far so good tonight. We've 2 questions down, 2 more to go. Might get a little bit more difficult here in the second half, but I think you guys are up for it. Want you to maybe stand up, take a stretch break. As you know, we are a team from USMLE-Rx, which is ultimate study tool for med students. We've got thousands of high yield questions. We've got over 1,300 express videos that explain every high yield topic in first aid. We've got over 13,000 flash facts, and if you haven't used the bricks, our RX bricks library continues to grow. We've got over 850 bricks, including a lot of free and open bricks. So our goal is to help you excel in your studies and reach your ultimate goal of becoming a competent and confident physician. We've designed the platform to adapt to your unique learning preferences, and we really want to make the process of studying more efficient and more effective, because you've got a lot that you need to cover and a lot that you need to practice on. So, with all these tools, we want you to be able to step into that Prometric Center or step into the exam room and achieve the best possible results. So, with our tools designed to help you, study smarter, not harder, and hopefully reach, that the residency of your dreams. We do have a USMLE-Rx special tonight that we're going to share after the at the end of tonight's event. So stay tuned. If you've been kind of on the fence about getting a subscription, this is going to be a good time for you. Okay. So with that, let's go ahead and jump into question number 3. So again, we've covered up those answer choices, and you can see the little heftier vignette in front of you. So let's read that lead in first. So which of the following enzymes contributes most directly to this patient's symptoms? Okay, just seeing that should help you help kind of frame your approach and tune your radar to the kind of data that's going to help you here. So with that, let's go ahead and read the vignette. A 44-year-old female comes to the emergency department with nausea, vomiting, and epigastric pain that has been radiating to her back for 12 hours. She has a history of recurrent episodes of right upper quadrant pain after eating. The patient is 175 centimeters, 5'9", and weighs 99 kilograms, 220 pounds. BMI is 32.5, temperature is 38, pulse is 120, blood pressure is 90/60. Lab tests reveal lipase of 248, alanine aminotransferase of 130, and aspartate aminotransferase of 95. Beta human chorionic gonadotropin is undetectable. So, with all that, let's read that lead in again. Which of the following enzymes contributes most directly to this patient's symptoms? Head on down to the question box. Let us know how many steps you think it's going to take to break this one down as I hand the mic over to Abraham.
All right, so a little bit trickier one here. Again, first thing you have to do is come up with a diagnosis. Then, what's the question asking? Let's go through and let's highlight the most important features here. Which of the following enzymes contributes most directly to the patient's symptoms? Okay, so it's not asking about diagnosis, it's asking about what enzyme contributed to the diagnosis. So I got you guys start thinking already here. So let's go from the top. 44-year-old female, a lot of F's. Presented to the ED, so had nausea, vomiting, epigastric pain. Okay, there's some classic, very non-specific, but the epigastric pain radiates to her back. That's a buzzword. And they've been having recurrent episodes of right upper quadrant pain after eating. So prior to all this happening, she was having this right upper quadrant pain, and then got this pain in the belly that goes to the back. She's a little obese, BMI 32.5, okay, and has a low-grade fever, okay. Blood pressure is a little bit low, so that kind of fits with the inflammatory, maybe something going on here picture. The lipase is 248. Interesting. ALT was 130 and AST is 95. And beta HCG is undetectable. That's not just that she's not pregnant. Okay, so you have all these kind of other things going on here. You have someone who's a little hypertensive, lipase is elevated, initially had this right upper quadrant pain, and then now has this epigastric pain that radiates to the back. So what's going to connect all these dots, come up with the diagnosis, and then which enzyme is directly contributing to the underlying diagnosis. All right. So if you don't get the diagnosis correct, this is going to be a lot harder. But if you get the diagnosis, then it's one step closer to the correct answer. All right. So let's look at the options here. Okay. So we have, again, 5 options. Let's look at which enzyme is the correct answer. Okay. Option E is trypsin. Option D is pepsinogen. Option C is enterokinase. Option B is elastase. Option A is amylase. All of these are enzymes in one way or another, but which is contributing to the underlying issue? And that's what the question is asking. So I want you guys to think about this one, connect the dots, and let's take an answer.
Okay. You've got your marching orders, so go ahead and pick your enzyme here. Always helpful to see how Abraham slices and dices a question. Again, lots of different ways you can go about it, but the thing is, you are going to be hit with some of those long vignettes that are really heavy when it comes to whether it's lab results or vital signs or what have you, and being able to to figure out what's relevant or what is what's a key abnormal. It's going to be very helpful for you. Okay, so let's see. Kind of looking at the results so far. It's a 2-horse race. We got 2 of the answer options are almost tied. So if you have not cast your vote, go ahead and do that now. I'm going to close the poll here in just a few seconds. As Abraham noted, you never want to leave a question unanswered on test day. You never want to leave a question unanswered during question lab. Okay, so we've got just over 3/4 of you voted. So I'm going to close the poll and share the results. So as I said, this was a 2-horse race. It was split between amylase and trypsin. We had a few that went with enterokinase and pepsinogen, but it was really between A and E. So let's see. I'm going to hide the results, and we'll share the answer. And the answer is answer choice E, trypsin. Very close. It got edged out by amylase, so can't really call that a win for the crowd, although quite a few of you did get that right, which is great. But there's something about this here, right, that was leading some of you towards amylase or the other answer choices. So this will be a good one to break down. So I'll let Abraham do that now.
All right. Good try, guys. It was very close, and I think I can see why you guys picked amylase. It's definitely the big distractor in this one, and you can see it up in front, right at option A. They want you to pick that as the second answer, and that is the trap you don't want to fall for. So let's think about why that's not the answer. Let's think about what's going on. And I saw a lot of you guys mention it in the questions. The F's, right? Fat, female, fertile, 40. And she's 40 years old, she's female, you assume she's fertile, and she's obese, right? Good BMI 32.5. So she matches the criteria for us to think about gallstones. Why do we think gallstones? Well, she has right upper quadrant pain. She's got colitis. She's got gallstones. Now, what can gallstones lead to that can cause this severe epigastric pain that radiates the back? Well, gallstones can get dislodged from the gallbladder and make its way down and block the duct for the pancreas. And if you block the duct of the pancreas, well, where's the pancreas going to dump all its enzymes? Well, it can't. It's going to just get stuck, and it's going to trigger a pancreatitis. So this patient has acute pancreatitis. Acute pancreatitis is a very inflammatory condition. It puts your body kind of into this shock of inflammation. It can put your blood pressure down, heart rate up, can trigger fevers, make you not want to eat, and it's going to cause significant amount of pain. And that's why, the main treatment is fluids and pain meds, and you allow that inflammation to come down. There's other associations with pancreatitis, which I'm not going to go into today, but it's a very high yield condition, and because it's common. We see pancreatitis a lot. When you think pancreatitis, think either alcohol is the most common. Number 2 is gallstones, and those can be interchangeable sometimes. But in this situation, fat female 40, think gallstones. All right, so we got our diagnosis. Pancreatitis, acute pancreatitis, big difference. Now, what enzyme contributes? This is the basic science of it. This is the step 1 part of this question. Now, we know that the pancreas secretes a bunch of enzymes, and that's the main job of the pancreas. It's going to secrete enzymes to break down food. For example, lipase and amylase are both enzymes the pancreas secretes. Lipase breaks down fats, amylase breaks down carbohydrates. But it is not what's triggering it. What about elastase? Well, elastase is also secreted by the pancreas, but it's secreted in a precursor form called proelastase. Okay. The most important thing here is, why is trypsin the answer? Trypsin is the main activator of all these proenzymes. So all the enzymes that haven't been turned on yet, they need trypsin on in order to turn everything else on. Trypsin is like the mastermind of the pancreas. Out of all the enzymes the pancreas secretes, trypsin is the one that's going to activate everybody else. It's going to say, hey, everyone turn on, so do your job. So when you have a blocked duct with a stone, then the pancreas will just start secreting things, and then the trypsin will turn on and subsequently turn on the other enzymes, which can then trigger the pancreatitis. Option C and option D, those are a little bit different, okay? Enterokinase is actually a brush border enzyme, so that's secreted in the actual brush border of the intestines, and that's going to convert trypsinogen to trypsin. That's not secreted from the pancreas. What about pepsinogen? Pepsinogen is from the stomach. That's going to convert pepsinogen to pepsin when exposed to the gastric acid. That's a different story as well. But in this situation, when I think what's the main driver for pancreatitis, trypsin is your villain. That's the one that's triggering the pancreatitis, turning on all the other enzymes, making the pancreas digest itself, called autodigestion, or saponification, sometimes they'll use the word. So a lot of these fancy words, all that means is that the pancreas is being overactive, and instead of using the enzymes to digest food, it digests itself. And that triggers acute pancreatitis.
Okay, everybody. So nice work. Again, definitely, that's a tough question, and easy to get led down the wrong alleyway. Hopefully, you'll be able to answer this one properly on test day. Okay, so we are at the end of tonight's session. So we are at question 4. So want everyone to really focus here. Let's see if we can finish strong. And what we're going to do is we're going to open it up and read that lead in. Which of the following most likely resulted in the development of this patient's kidney stones? Okay, so a very specific type of lead in, and we know that the patient has kidney stones even before we read the vignette. So let's go ahead and check out the story, knowing that there's some clues that we may need to key in on. A 28-year-old man with Crohn disease comes to the emergency department because of a 24-hour history of flank pain with radiation to his groin. For the past several months, he has had diarrhea with foul-smelling stools that float in the toilet. His diet and appetite are normal, and he drinks extra fluids each day to avoid dehydration. Vital signs are normal. Physical examination shows left costovertebral angle tenderness. Laboratory testing shows normal serum calcium and phosphate levels. Urinalysis shows specific gravity of 1.010, pH of 5.5, 3 plus blood, and numerous crystals. Okay, so again, the lead-in. Which of the following most likely resulted in the development of this patient's kidney stones? Think about how many steps it's going to take you to solve this one. Let us know down there in the question box as I turn it over to Abraham.
All right, so another little tricky one here. So this one kind of already tells you, just like Jeff said, the patient has kidney stones. You got to kind of work backwards and think about what caused this kidney stone. So let's highlight some keywords and let's see what's going on, what triggered all of this. So, resulted in the development of the patient's kidney stones. Okay, good. You got that lead in, you know what you're looking for. Let's go into the question. So a 28-year-old man, okay, he has a history of Crohn's disease. That's high yield. They're telling you straight up. They're not even making you guess what's going on. So you already know the patient has Crohn's disease. Now, what's the association between Crohn's disease and kidney stones? Is there an association? And had 24-hour history of flank pain radiating to groin. Okay, we already know this person has kidney stones, so don't even worry too much about what these symptoms are. Diarrhea, foul-smelling stools afloat in the toilet. What does that mean? So we know that Crohn's people get diarrhea. What are these stools that are floating in the toilet? Okay, what could that indicate? And physical exam, again, left CVA, costovertebral angle tenderness, also kind of points more towards the kidney stone picture. And you see blood in the urine with numerous crystals. Interesting. So what is making this connection? How am I going to connect one to the other? And how does Crohn's disease, or is there something else that I'm missing that is triggering this kidney stone? All right, so let's look at the options here. Let's break it down, and then let's try to get to the answer here. This one's a tough one. So we have, again, 5 options here. Again, I want to take your time, read through them. Don't get tricked out. Again, these are different mechanisms, right? They're not just giving you a diagnosis. So these are the hard ones where you have to think that extra step of what's happening and why it's happening. The pathophysiology is the most high yield part of this. All right, let's look at option E, increased urinary excretion of calcium. Okay. Option D, excess intestinal lipids. Option C, dehydration. Option B, decreased dietary intake of calcium. Option A, decreased bile acid production. Again, all these are different mechanisms, and some of them may cause kidney stone, but what caused the kidney stone in this 28-year-old male with Crohn's disease? That's the question. How am I going to make that connection? All right, take a moment, go through the options, see the highlighted key features here, and let's try to think of what the answer could be here.
Okay, with that, we have launched the poll for our final question tonight. So, had quite a bit to parse from that vignette. Trying to figure out what likely resulted in the development of the kidney stones in this 28-year-old male. Just a quick note, we will have a raffle here at the end of tonight's session. And you do need to be present in order to win. And a couple of things that we'll also share regarding special promotions and special tools. Put links to the our free RX study planner in the chat, as well as a reminder about our free self-assessment exam week, which is going on right now. Let's take a look at our votes. This is question number 3 was a 2-horse race. This one is a little bit more of a 3-horse race. So let's go ahead and close the poll and share the results. So increased urinary excretion of calcium was the top vote getter, but it was excess intestinal lipids was right on its heels, whereas decreased bile acid production just a little bit behind that with 26%. Okay, and then a few votes for decreased dietary intake of calcium and dehydration. Okay, so with that, I'm going to hide the results, and we are going to share the answer. And the answer is answer choice D, excess intestinal lipids. Again, just narrowly beat out by answer choice E in terms of votes, but again, tough question. Well done, everybody that got that one. And if you didn't get it, or maybe you were thinking this and decided to go with a different option, that's okay. Abraham's going to walk us through this one.
All right, off by 1% again. Very close, guys. So this is another high yield topic here, and it's high yield because it's multi-system, right? It wants you to think about the kidneys and the GI tract at the same time. They love these multi-system questions. They love connections that can test you on a couple things at one time with just one clean question. And very high yield here. Let's kind of break down what's going on, right? So we already know he has Crohn's. We know he has some kidney stones. Now, what's the association here? Let's break down pathophysiology of Crohn's disease. And what are these stools that are floating, right? So fat floats. This is steatorrhea. This is a patient who's having malabsorption from Crohn's, which is leading to fat loss in the stool. Now, having fat in your stool or intestinal lipids, excess intestinal lipids, why would that cause kidney stones? Well, this is a very high yield concept to understand. Fat loves to bind to calcium. That's what we've known all the time. Every time we put a bunch of fat somewhere, calcium loves to bind to it. Okay, that's just it works the chemistry of it. That just calcium likes fat. You got to build that to memory. Now, when you have all this excess fat in your intestines, all the calcium is binding to that. So what is the calcium not binding to because it's binding to the fat? Well, that's leaving oxalate by itself. Oxalate's a single lady. It likes to bind to calcium normally and be excreted in the stool. Now, oxalate's by itself, unbound. Now, when an unbound oxalate is floating out in our intestines, what's our body going to do? Absorb it into our bloodstream. That's going to increase the amount of oxalate our body takes in from the GI tract. And we generally don't like having oxalate by itself floating around, because what does it do? It binds to calcium and forms stones called calcium oxalate stones. So by a result of us having fat in our intestines, our calcium's already bound to that fat, which frees up this oxalate, which then gets absorbed into our bloodstream and makes its way into the kidney, where it binds to calcium and finds its pair, makes crystals in the kidney, and leads to kidney stones. So calcium oxalate stones can be seen in conditions that cause malabsorption. So not only Crohn's disease, any conditions that are associated with malabsorption and increased fat in the stools can lead to calcium oxalate kidney stones. Very, very high yield, multi-steps, makes you kind of think, visualize what's going on, and very important to understand. Let's look at the other options here, just kind of make sure why it's not the other ones. Option A, decreased bile acid production. Well, that's not something that's typically seen in Crohn's disease. There is a reduction, but it's not what's important here. That's not, you have a decreased bile acid absorption in Crohn's disease, but it's not what's causing the stone, not really what's high yield here. Option B, well, reduced intake of calcium. Well, technically, yes, if I have reduced intake of calcium, I can have more oxalate absorb into my GI tract and cause a stone the same way. But that's not what's causing the stones here. It's because of the fat binding to the calcium. It's not because I'm not eating enough calcium. Dehydration. Well, dehydration does cause kidney stones. We know that. That's if you dehydrate something, things crystallize. But the patient is drinking enough water, is euvolemic on exam. Nothing indicates the person is dehydrated in any way. And if you look at the urine-specific gravity, it's 1, right? It's normal. You're not thinking he's dehydrated in any way. And option E, increased urinary excretion of calcium. That will caught everybody. Of course, if you excrete out a lot of calcium in your urine, you can't get stones. That's another cause. But Crohn's wouldn't cause that. What's going to cause that? Primary hyperparathyroidism, idiopathic hypercalciuria, lots of things that other reasons why you may secrete calcium into your urine. But in this situation, the Crohn's is leading to malabsorption of fat. Fat binds to calcium. Oxalate, therefore, is single, gets absorbed into the bloodstream, goes to the kidney, binds to calcium, forms the crystal. Very high yield.
Okay, everybody. Again, hats off to everybody. I'm not sure. I'm sure there are probably a few of you went 4 for 4. If you do, let us know here in the question box. But good job, everybody. And even if you went over 4, the key thing here is that you walked out of tonight's session having learned something and perhaps gained some insights on how to answer these questions. Since there's so many different variables that go into to the success on test day. So anyway, hats off to all of you. You guys all showed up today, and that's fantastic. If you go to the chat box, and if you've got either a Step 1 QMax or an RX 360 Plus subscription, I've actually put a link to the questions in tonight's test that you can check out, or you can just copy down the QIDs here from the screen. So go ahead, you can screenshot that, get it down. And a nice thing about that is that you can always kind of go through all those explanations and see, the relevant bricks and flashbacks and videos to help you with some of the underlying concepts.